Bueno, hola de nuevo a todos. Después de este break, coffee break, empezaremos la segunda mesa dirigida a la actualización terapéutica de las bronquiectasias. Tendremos 3 charlas maravillosas, componentes de altísimo nivel y que creo que será de gran interés para todos los asistentes. Vamos a empezar con el primer tema, que es sobre nuevos tratamientos farmacológicos en bronquiectasias. Esta charla será en inglés. Tenemos el honor de tener aquí al Dr. James Chalmers, que no solamente es el jefe de la división de respiratorio de la Universidad de Dundee y del Hospital Nine Wells, sino que es, digamos, uno de los padres de las bronquiectasias modernas. y thank you, James, for being here. It's a great honor to introduce you. You've been a key person in the development of new strategies in bronchiectasis, and personally as well for my interest in this disease. So the floor is yours.
Thank you so much. So thank you to the chairs, and thank you to Oriol for the invitation to come and speak to you. And it's a really nice time to be coming to speak to you. If I'd given you this talk 5 years ago, I wouldn't have any new therapies for bronchiectasis to talk to you about, or I'd be telling you about antibiotics, which we've had since the 1950s. But today I do have news to tell you, which is really exciting. These are my disclosures. This slide is important because I'm going to show you results of studies that I've performed with these companies, so important that you're aware that I do have a conflict of interest working with these companies. So we need new therapies for bronchiectasis. Most of the therapies that we have are established since the introduction of antibiotics in the 1950s, inhaled antibiotics, macrolides. These are useful tools, and you'll hear more about them in the subsequent presentation, but they aren't adequate to the burden of disease. We need therapies that can reduce exacerbations and slow disease progression. We also have a problem that because we have not enough good therapies, we use a lot of therapies in bronchiectasis where there's limited evidence. And you can see from the EMBARC data here, this is the European registry data with nearly 17,000 patients, that around half of patients with bronchiectasis are on inhaled steroid. There's no randomized trial data that shows that that's appropriate, and the guidelines say not to do that. And we have some interesting geographical variations. So you see carbocisteine and N-acetylcysteine in my country, the UK, almost 1/3 of patients receive it. There is no trial data that suggests that that's effective. I don't know why we do that in the UK and we don't do it in other places. But what this tells you, when you see a lot of variation between regions in how we treat something, is that the evidence base is weak, and a lot of it is based on culture and what people have been taught to do. And that's a challenge for us as scientists and clinicians. We need to do clinical trials, and we need to show people what works and what doesn't work. So we need better evidence-based treatments. And one of the key targets for new treatments is inflammation. So the revolution in asthma was recognizing that it was an inflammatory disease, mostly driven by T2 inflammation, and anti-inflammatory treatments like inhaled steroid and then the biologics tackle that inflammation and have really changed everything about how we think about and then treat diseases like asthma. Can we do the same thing in bronchiectasis? Well, it's not a T2-driven disease in most patients. It's a neutrophil-driven disease. Neutrophils are the most abundant white blood cell in your body. They migrate to the airway. They produce these webs of DNA called neutrophil extracellular traps that I will talk about a bit later, firing webs out almost like Spider-Man to capture pathogens, and that causes a lot of damage to the lung. And so targeting neutrophilic inflammation is a potential strategy to improve outcomes in these patients. And there's good evidence that having too much neutrophilic inflammation in the lungs is a bad thing. If we look at, this is proteomic data from sputum of bronchiectasis patients. We've also done this in BAL. The red here is severe patients. Oh, there we go. The red is severe patients. The blue is mild patients. The severe patients are clustered together, and the cluster identifies things like neutrophil elastase, human leukocyte elastase, myeloperoxidase, azuricidin, proteins I'll talk about a bit later, that are associated with worse outcome. And so patients who have more neutrophils have worse outcomes and more severe disease. We also know from studies of the peripheral blood neutrophils that they have impaired function. They don't kill bacteria as well. They have altered metabolism. So these cells are altered in people with bronchiectasis even before they reach the lung. suggesting that we need to do something systemic to alter the neutrophil function if we want to improve outcomes in these patients. This has important downstream effects on other aspects of your host defense, as I'll show later. And if you do a simple measurement of neutrophilic inflammation using an assay like neutrophil elastase, this is a study that we published in 2017, people who have high levels of this target have more exacerbations. And in this study, we showed two things: that neutrophil elastase was associated with exacerbations, and secondly, that people with high levels had more rapid lung function decline. And so that's important because you would then predict that a therapy that targets this would reduce exacerbations and slow lung function decline. But we needed to prove that. So the neutrophilic response has important implications for what happens in bronchiectasis. You'll see during this course lots of vicious cycles. I've deliberately not put a vicious cycle into my presentation to give you a break from the vicious cycle. But this is what happens in bronchiectasis. The neutrophils come into the airway. They release all of these mediators, and neutrophil elastase is particularly important. That destroys your anti-protease defense. So that gets rid of the balancing effect that tries to control inflammation. It impairs the clearance of bacteria, so you get chronic bacterial infection with things like Pseudomonas. And the major driver for the production of MUC5AC, which is your main pro-inflammatory mucin, is inflammation. This mucin is stored in the granules of epithelial cells. If they're exposed to protease, they spit out the mucin. So all the things that you see in your patient, mucus hypersecretion, cough, chronic bacterial infection, these are all linked to the levels of inflammation and can be directly causally linked to the levels of inflammation. So in theory, if you could target this, maybe you would have less infection. You may also see less mucus and improved symptoms. That's the theory. In order to do that, we need an approach, a therapeutic approach that can make a difference. And in fact, targeting neutrophils has been very difficult because you need effective neutrophils to clear bacterial infection. So if you just had a mepolizumab or a benralizumab for neutrophils and you could just wipe out all of the neutrophils in your body, that would be a disaster because you need them to fight infection. Anyone who's managed a neutropenic sepsis patient will recognize that. So you need a much more sophisticated approach to reduce inflammation when it comes to neutrophils. And so going to genetics, there's a rare genetic syndrome called Papillon-Lefèvre syndrome. It's very rare, 1 in a million people, and they lack an enzyme called DPP1. And what's special about this disease is that it's autosomal recessive, very rare. The patients have altered neutrophil function, but they don't get an increased risk of infection. And as you can see on the right-hand side here, their killing of gram-negative and gram-positive bacteria is preserved. So they have reduced ability to make these nets, these webs that I talked about. They don't have active neutrophil elastase. It's completely absent in most of these patients, but they're still able to kill bacteria. So it sounds like a really good drug target because you could reduce, if you target it, you could reduce inflammation, but not create infection problems. Of course, it's a condition, and so there are manifestations of this condition, and the two most common are problems with thickening of the hands and feet, which is called hyperkeratosis, and problems with early periodontitis, so people lose teeth, and the mechanisms of those are not really well known and still not really well known. And so if you were going to target this, you'd have to look carefully for side effects related to skin and teeth. So persuading people to do studies in neutrophils has been challenging because there's been various attempts to do this, also in COPD. CXCR2 antagonists were tested in COPD, but increased the risk of infection. LTB4 antagonists were tested in CF, increased the risk of infection. This is this issue with reducing the number of neutrophils. And so what we've now done with cathepsin C or DPP1 inhibition is targeting neutrophils right at the start of their life cycle. You make neutrophils in your bone marrow. They mature in the bone marrow till they're ready to be released, and then they pass into the circulation and eventually make their way to the lung. What the DPP1 inhibitors do is they block the activation of neutrophil elastase, proteinase 3, and cathepsin G in the bone marrow. So neutrophils are then released into the circulation, pass through the blood vessels into the lung, but they lack these enzymes that cause all of the damage to the airways. So the hypothesis is, again, that the drugs will mean reduced inflammation without increased risk of problems. That's all really nice in theory, but we need to test that in patients. So I'm now going to show you a series of clinical studies with DPP-1 inhibitors in patients with bronchiectasis, starting with the phase 2 study that was published in 2020. So this was the first human study with a DPP-1 inhibitor. It tested 25 milligrams of brensocatib, 10 milligrams against placebo, and it was for 6 months. So this was, for a phase 2 of a novel compound, to do a 6-month phase 2 was a really brave thing to do, but I think a really important thing to do, because rather than looking at biomarkers, we looked at a clinically relevant outcome, which is time to first exacerbation. And we took sputum samples regularly during the study so that we could look at the biology of this drug, which is important. And it was a positive study. So what you see here is the Kaplan-Meier curves with the frequency of exacerbation, the time to first exacerbation. So about half the patients in the placebo group had an exacerbation over 6 months, and that was reduced by about 40% at both doses. So there's no difference between the 10 milligram and the 25 milligram in the exacerbation endpoint, and we'll come back to that. In the sputum samples that we took, remember the clever pharmacology of this. It works in the bone marrow, so it takes time for the neutrophils to be released into the blood. So at 2 weeks, the levels of inflammation are not down that much in the lung, but at 4 weeks, they're dramatically reduced. All the neutrophils have been turned over. The old ones in the lung have died. The new ones have come in. They lack these enzymes, and so you have large, massive reductions in inflammation. This is a log scale, so this is greater than 90% inhibition of the enzyme. It's really quite striking, and the same is true for cathepsin G. So very effective anti-inflammatory effect, and that translates into reduced exacerbations, which is what we were hoping to see. I said already that you would predict, based on what we know about the biology of neutrophil elastase, that if you have that effect on the biomarker that's going down by 90%, you should also see effects on other aspects of the inflammatory cascade. And I'm focusing here particularly on your antimicrobial proteins like SLPI, that I know there's been a lot of work done on SLPI here in Barcelona, and mucus, which is related to symptoms and is clearly very important in people with bronchiectasis. So in order to investigate that, we've done a couple of other studies. So this is a study where we took neutrophils from the blood of people who were taking brensocatib or taking placebo. And this data is not published yet, but it was presented at the ATS. And what we saw was that there was a significant reduction in other proteins, not just the classical neutrophil elastase, proteinase 3, and cathepsin G. So actually this new protein called azurecidin is reduced dramatically by brensocatib. So that's an additional novel anti-inflammatory effect of the drug. And we think that that's also because it needs to be activated by the enzyme cathepsin C. You can see elastase goes down, you can see cathepsin G goes down, all the things that we expect. And then something really nice is defensin A3 is an antimicrobial protein that fights bacteria and viruses, and that's increased by this drug, and that's because it's no longer being degraded by the proteases. And we've been able to show that. So it has broader anti-inflammatory effects than we think. It also has or antimicrobial or antiviral effects in addition. And then that was in neutrophils themselves. This is now in the sputum in the Willow study. You can see that marked reduction in these inflammatory proteins. But importantly, from a patient symptom perspective, this is MUC5AC, significantly reduced, particularly at the 25 milligram dose. And if you're wondering why they go up at the end, it's because there's a 4-week period off the drug at the end of the study. So that's showing the change once you stop the drug. And it's notable that the mucins are still down 4 weeks after you stop the drug, which is an interesting phenomenon that we're investigating further. So you might predict from MUC5AC going down that patients would notice less cough and sputum. And these are the antimicrobial proteins. This is defensin, validating what we saw in the neutrophils. There's this nice anti-inflammatory effect, and the same is true with SLPI. And again, these are log scales, so the differences are actually huge. So this is exciting. This reduces exacerbations, has a big effect on reducing inflammation, and it's reversing some of the key pathophysiological features that have been described in bronchiectasis. What other evidence have we got that this works? Well, there's 2 other phase 2 studies of different compounds in this class. So the first one I'm going to show you is BI 1291583. Needs a catchier name than that. And this is another compound. It's a different compound that works through the same mechanism. It's DPP-1 CAT-C. And in this study, 1 milligram, 2.5 milligrams, or 5 milligrams, it was a dose-finding study, were compared to placebo. And this was a phase 2, but a big one, 322 patients in total. There were some unique aspects of this study. The Willow study enrolled people with 2 or more exacerbations. This one enrolled patients with 1 or more. This study also allowed people with COPD or asthma as a primary diagnosis, as long as they also had bronchiectasis. And what you saw is, so this is a slightly difficult to interpret graph, but this is the effect estimate. So 1 means no effect. The 1 milligram dose has no effect, but you've got a 30% reduction in exacerbations with the 2.5 milligram and the same with the 5 milligram. Looks a bit like brensocatib, doesn't it? Because of the 2.5 and the 5 being very similar. And you can see that also with the Kaplan-Meier curves, that the 1 and the placebo are together, the 2.5 and the 5 are together, with about a 30% prolongation of the time to first exacerbation. And this difference here was statistically significant, so that's a positive phase 2, and that's now moving into phase 3 that should kick off soon. And then the third compound that I'm going to show you, and this has just been published in the Lancet Respiratory Medicine, is one that was conducted exclusively in China. 40 milligrams of a HSK 31858, 20 milligrams against placebo. This was a carbon copy of the Willow study, a 6-month trial with exacerbations as the endpoint. But look at these effect estimates. So Willow hit about 40%. Here you've got 46% in the 20 milligram and 60% reduction in exacerbations with the 40 milligram. So it seems that there is a larger effect in people from China, and that may be due to the fact that the background exacerbation rate was much higher. And in China, there's certainly a lot less use of things like macrolide, inhaled steroid, other background therapies. So that may also be influencing some of that. But it's very rare in bronchiectasis we get a positive study. It's really rare we get 3 positive studies in a row. So it looks like DPP1 inhibition really robustly reduces exacerbations. But most of these studies are not powered sufficiently to look at other endpoints, and they're not definitive because they're phase 2s. They have to go to a phase 3. And so just last week in the New England Journal of Medicine, the phase 3 results of brensocatib were published. This is by far the largest trial ever conducted in bronchiectasis. It's more than 1,700 patients. It's the 2 doses that showed positive results in the Willow study were taken forward into the Aspen study, which is the name of the phase 3, 25 milligrams, 10 milligrams against placebo. It's a 1-year study. The primary outcome was frequency of exacerbations, with secondary outcomes being lung function decline and symptoms based on the observations that we'd made about the biology and the likely benefits of these treatments. And there was an off-treatment period as well. And this is the primary outcome data. So the primary outcome was met. The pre-specified p-value threshold required for a positive study was 0.01, so it beat that. And there's a 20% reduction in exacerbations at both doses, with no obvious difference between the 10 milligram and the 25. So across all of these studies, it seems that once you reach a certain level of inhibition, you don't get additional exacerbation benefit by ramping up the dose. They all look almost exactly the same in terms of dosing, that you reach a kind of ceiling effect for exacerbations. But there is a difference when it comes to dosing in the secondary endpoints. And here the 25 milligram beats the 10. So with lung function, this is not a bronchodilator. We're not expecting lung function to increase. But what you see in bronchiectasis patients is an accelerated lung function decline. And you can see that with the placebo group dropping by 62 mils per year, which is relatively rapid lung function decline. And again, as we see with all of these things, it takes a while for the drug to work because it has to work its way through that bone marrow life cycle. But after 16 weeks, the lung function curve flattens in people who are taking brensocatib at the 25 milligram dose, but there's no effect at the 10 milligram dose, which is very interesting. But we can say, because the p-value is 0.054, we can slow down lung function decline. And then in terms of quality of life or symptoms, the quality of life bronchiectasis respiratory symptom domain is driven by things like cough, sputum, breathlessness. And what you see is that all of the groups are improving. There's a large placebo effect, and we see that in all of the trials that you do in bronchiectasis. But there's clearly an additional benefit, particularly of the 25 milligram, where patients are feeling better. And the difference, the improvement overall in the study for the 25 milligram dose is 8.6 points. The minimum clinically important difference is 8. So a lot of these patients will be noticing that they feel a lot better. And the difference between the groups is statistically significant. Now, I have to make a technical note here that because of the statistical hierarchy, this is not technically statistically significant. But if you ask me as a clinician, are patients going to feel better when they take the drug? The answer is yes. It's the difference between a statistician and a clinician. We also did a daily diary during the study. And that was called the BEST diary, and we saw exactly the same pattern, that patients on the 25 milligram dose felt better on their daily symptoms, but there didn't seem to be an effect of the 10. And so that's potentially important. No difference in exacerbations, but there is a difference in the symptoms and the lung function. And that feeds into the question I get often asked, which is, when this becomes available, are you going to use the 25 or the 10? And maybe we can talk about that during the discussion session. So this is really exciting. This is the first unequivocally positive phase 3 study ever in bronchiectasis. It's very likely to lead to regulatory approval, but that's still pending, due to have a decision in the US, we think, in August, and then hopefully the company's announced next year is the target for Europe and Japan. So these data are important, and they start to generate new questions about what should we be doing with our patients. In most inflammatory diseases, what you try and do is prevent damage. If you think about our asthma guidelines, they don't say wait until somebody's got fixed airflow obstruction and then start your ICS. They say you should be trying to prevent lung damage from the earliest stages of the disease. And bronchiectasis, unfortunately, is a disease that's defined by destruction of the airways. So by definition, by the time you get into one of these studies, you've got a lot of destruction of the airways and a lot of impairment of lung function. So I think this because it seems to be able to prevent disease progression, it raises questions of, would you see better response if you start the drug earlier? All of the subgroup data looks like it's consistent across multiple endpoints. So if I show you the forest plots for exacerbations, it looks like almost every group has a similar response to the overall. This is for lung function, and anything to the right is a benefit. And you see almost every subgroup looks almost exactly the same to the right, with a couple of exceptions. And the exception I'll highlight is there was a small cohort of adolescents in the study between 12 and 18 years. And the benefit on lung function, the estimate's 324 mils in that group. I'll zoom in to that group, which is remarkable. And if you look at the curves, which I haven't got to show you, but we can discuss later, that group declines very, very rapidly in the placebo group, which maybe gives us a hint towards the idea that treating people earlier is the way that we will want to go with these kind of therapies in future. So we're going to have a new therapy. I think we've got some really exciting thoughts, ideas, and questions to answer around how we use them in the future. This is a major milestone for bronchiectasis. Just before the trial results were published, my friend Sanjay Chottamal and I published this in the Blue Journal, sort of mapping the history of bronchiectasis. And it's amazing to think that if we go back to the early 2010s, there were essentially no clinical trials running. The only things that were going on were small studies of inhaled antibiotics, and there'd been one failed trial of repurposing DNAs in bronchiectasis. The progress that's been made from almost nothing happening in the 2010s to now a positive phase 3, but multiple other compounds now being developed, is really, really exciting, and it's great for patients with bronchiectasis that we're entering a different era now for the disease. Because DPP1 is fantastic, but it's not the only target that we can use to target inflammation in people with bronchiectasis. The DPP1 inhibitors are here. They target neutrophil serine proteases, but there are multiple other ways of targeting inflammation, and we've characterized that bronchiectasis is a complex inflammatory process. You have increased IL-6, which is obviously targetable. IL-1 beta is very important, and Lydia published a fantastic paper on that last year in the ERJ. That's targetable. We've got drugs already in clinical use that can target IL-1 beta. And there is a T2 inflammatory process in bronchiectasis in around 20 to 30% of patients, and there are clearly very good drugs that target that. But a couple of the other things I'll highlight that are now in clinical trials have broader anti-inflammatory effects, and one is anti-IL-33. So an anti-IL-33 study is currently enrolling for people with bronchiectasis, and this is also being developed in COPD. IL-33 is interesting from a bronchiectasis standpoint because it's an alarmin. So when you get an exacerbation, often that's triggered by a virus. The virus hits the epithelium releases this alarm signal, which is IL-33, saying, help, I've got a problem, and that stimulates a big inflammatory response. But it's not just driven by neutrophils, it's driven by macrophages, eosinophils, and by your adaptive immune system. And so by targeting IL-33, the idea is that you will cut the frequency of exacerbations by preventing that overexuberant response to viral infection or other triggers. And that there's, as I mentioned, a trial of itepekimab, which I always struggle to say, in bronchiectasis that's likely to report results next year. There's an additional nice paper that came out in the ERJ last year, 18 months ago, that looked at IL-33 and showed this very interesting biology. The IL-33, when it gets oxidized, and there's a lot of oxidative stress in the bronchiectasis airway, signals through the RAGE receptor to produce lots of MUC5AC, going back to why are our patients symptomatic? Because they've got too much mucin in their airways. So the concept here was that if you block IL-33, the patients will notice a symptom improvement because it should block the excessive production of mucus. That's been shown in cells. We're going to find out very soon whether that also is the case in patients' airways. And the other one that's now kicking off a randomized clinical trial is PDE3, PDE4 inhibition. So this is ensifentrine, which has recently been licensed for COPD in the US and is now being tested in bronchiectasis. So this has multiple modes of action. So PDE3 and PDE4 together have a bronchodilator effect, and that was the main thing that was looked at in COPD. But there is a well-characterized anti-inflammatory effect, particularly with the PDE4 component of this. And there are in vitro studies that show it hydrates mucus through CFTR activation and can speed up cilia function. So there's lots of reasons to think that this may work in bronchiectasis. And there was encouraging results in COPD in the enhanced studies where there was a reduction in exacerbations in people with COPD. But we will find out very soon from the phase 2 study whether this is an effective strategy. And the last study I'm going to show you the results of, I'll just check how I'm doing for time. Yeah, good. The last study I'm going to show you the results of is actually phage therapy. So all of the anti-inflammatory strategies are really nice. I think bronchiectasis is predominantly an inflammatory-driven disease, just like I think COPD and asthma are predominantly inflammatory-driven diseases. I think what determines the outcome of an injury is how your immune system responds, and I think that's, at least in later stage disease in bronchiectasis, a key driver of pathology. But there's no question that people who've got Pseudomonas infection do badly. And Oriol will talk about inhaled antibiotics later, but inhaled antibiotics have given us somewhat inconsistent results. They aren't liked by all patients. So we clearly need alternatives also for Pseudomonas infections specifically. There's been a lot of really nice case reports with phage therapy where people report, we took phages from sewage or we took phages from somewhere, we tested it in the lab, we gave it to our patients and the Pseudomonas was gone. But it's not really been tested in a proper randomized clinical trial until now. So this is unpublished data, but this is data that's in the public domain from a compound called APPA02. This is a nebulized phage product that was tested in a randomized study in the US. It's previously shown some encouraging results in CF in a small study, and so they took this to bronchiectasis with a 10-day treatment with the nebulized phage. And then followed patients up post-administration. And they included a cohort of patients who were not taking any background antibiotics, but they also included some people who were taking inhaled antibiotics because there's some evidence that when you give phage, it makes bacteria more susceptible to antibiotics. So the idea is a kind of synergy between antibiotics and phage. And so it's quite clever that they did essentially both within the same clinical trial. It's a small study, so it's only 48 subjects, but the results are quite interesting. So it's a negative study. So on the left-hand side, you can see cohort A, which is the people without antibiotics. This is the CFU, which is the level of Pseudomonas in the sputum, and it is reduced in the people receiving phage, but actually there's a lot of patients there who are having no response at all. There's no reduction in their CFU from baseline to the end of treatment. And the same is true for the cohort B, although you can see the number of dots is quite small, so the number of people who are on antibiotics is actually relatively small in the study. But there is a bit of a signal. So if you look on the right-hand side, this is now the trajectory, not just the one time point, but the trajectory during the study. At day 10, which is the end of treatment, there's a bit of a drop, which is what's shown in the other graph. But there seems to be a bit more of a drop after the treatment's been discontinued, and that persists. And there are some of these time points where it's statistically significant. There's clearly no effect in any way in the placebo group. So this is not a positive study. It's not a completely negative study. There's a signal. What I think I would take from it is that phage is not a miracle. Yeah? If you read a lot of these case reports that are in high-impact journals, they describe phage curing these chronic infections within a few days of taking the phage. That's clearly not the case when you do a careful, controlled, randomized study. But there is a signal here, and maybe there will be additional studies with phage going forward. But that still leaves us needing really good treatments for Pseudomonas infection beyond inhaled antibiotics. So I'm going to show you one more potential strategy. And this is data from a study that we published last year in the Blue Journal. So Pseudomonas causes infection of the airways through a number of virulence factors. Two of those virulence factors are called PCRV and PSL. They contribute to its ability to kill epithelial cells and therefore survive the epithelial response, and they allow it to evade the immune system, which is one of its major strategies to avoid being killed in the airway. And so we hypothesized that if you could disable these two virulence factors, you could actually reduce the ability of Pseudomonas to cause infection in the airway. And so we did a study sequencing Pseudomonas to make sure that Pseudomonas had these targets. And what you end up with here is that 73 out of 100 Pseudomonas isolates from people with bronchiectasis had the PSL gene, but 99 out of 100 had the PCRV, and there was only one organism that didn't have either of these targets. Why is that important? Because I'm going to tell you in a moment that we're going to test an antibody against these targets. If the bugs don't have the genes, the antibody won't bind. So the fact that almost all of the bugs have the gene means that the antibody should work against the vast majority of Pseudomonas isolates that are present in people with bronchiectasis. That's what that was all about. And we tested isolates from Europe, Central and Eastern Europe, but also Australia and New Zealand, just to see that there wasn't a global diversity in this. And so then we did some additional experiments where we took neutrophils from people with bronchiectasis, which you'll remember are impaired in their ability to kill Pseudomonas, and said if we give them the antibody, are they now able to kill the Pseudomonas? Because we've weakened the Pseudomonas and strengthened the neutrophils. And this is the result. So you see as we increase the amount of antibody, we're killing more Pseudomonas, up to about a 40% increase in the amount of Pseudomonal killing. And that's mediated by being able to eat them more effectively, phagocytose them more effectively. And if you test this in mice, I'm not a great believer in mice studies, but this is a way of showing in a whole organism system that the antibody works. If you give a Pseudomonas infection, the mice die within 48 hours. If you give the antibody or individual components of the antibody, there's no mortality in the mice. So this does look as if it's an effective strategy to reduce the virulence of Pseudomonas and therefore to tackle Pseudomonas infections. But that's in a petri dish and that's in a mouse. You want to know what it looks like in humans. And so we've recently completed, and here I have to say big thank you to Oriol, who coordinated this study in Spain. We've recently completed a randomized study called GREAT2, where we tested this antibody as a monthly injection in people with bronchiectasis against a placebo. All of them had baseline Pseudomonas infection, chronic Pseudomonas infection, and they were treated with antibody injections for 3 months as a proof of concept to see, does this work in patients? And I've been dying to tell people the results of this study for ages, but it's been embargoed because it's being presented at the ATS. But the ATS abstracts came online 2 days ago, so I'm allowed to tell you because it's in the public domain, and that's really exciting. I've been dying to tell people this. It works. It's really exciting. It works. So we tested 2 doses, 500 milligram and 1500 milligram. There's a significant reduction in bacterial load with the 500 milligram dose. The 1500 milligram dose looks very similar, but narrowly missed statistical significance, probably because of the sample size. But the thing that really blows me away is the improvement in symptoms. So there's a 12-point and a 10-point improvement in the St. George's Respiratory Questionnaire. I'll ask Alvar later if he's ever seen a COPD therapy that improves SGRQ by 10 or 12 points, but I doubt there's many. No. Yeah. It's amazing. I'm really amazed by those results. And even in a very small study, there was a significant reduction in exacerbations over 3 months at the 1500 milligram dose, and there were no major safety issues. So I've deliberately not shown you all of the data because I'm not stealing the thunder of the person that's going to present these data at the ATS. But as a top line, I think this is really exciting. And I have an ulterior motive to showing this, which is we're going to be doing a further study of this antibody and hoping Spain will strongly participate. So if you do get a contact from me saying, would you like to do the next study, please say yes. So that's really, really exciting. So I think I've got 5 minutes left. Yeah, 10 minutes left. So I've shown you loads of new therapies. I hope that the next 10 years, bronchiectasis is going to be one of the most dynamic fields in respiratory medicine. We're going to have DPP-1 inhibition, but we might also have IL-33. We may have monoclonal antibodies. We may have phage. Have loads of exciting new therapies for our patients. I think there's a very good chance that we'll do that because we've really shown that we can deliver these things. So how do we pick which patient should get these new therapies? How do we decide in a complex heterogeneous disease with multiple causes, with multiple different aspects to the disease, how we risk assess and how we decide what's the right treatment for the right patient? And you're going to get a talk very shortly on treatable traits, so I'm not going to completely focus on that, but that's kind of the answer. But I thought this is an interesting thing. Einstein's 2 quotes that everything should be made as simple as possible, but not simpler. There's always a pressure for us, I think, when we're writing guidelines or doing clinical trials, to make things really, really simple. But bronchiectasis is not simple. Bronchiectasis is a really complicated disease. And I'll show you some examples, but I think sometimes we try and make it too simple. And second is, if you can't explain it simply, you don't understand it well enough. Our job, I think, is, with all of these new therapies and the new things we're developing, to find ways of communicating to physicians, here's how you can find your way through the complexity. And Alvar has done that brilliantly through his career, but particularly with this concept of treatable traits. So I'm going to criticize myself now because I wrote the 2017 ERS guidelines for bronchiectasis, and I think we made them too simple. So we have this algorithm for antibiotic treatment, which says optimize airway clearance and underlying causes, and if they've got 3 or more exacerbations per year, inhaled antibiotics or macrolide. And I'm sure Oriol will talk about that later. That's really simple. 3 exacerbations, treat. But it's probably wrong. I mean, none of our trials actually enroll people with 3 or more exacerbations per year. And I showed you a slide at the beginning where you see these are very effective therapies. Less than 20% of our patients that are frequently exacerbating are on macrolides. Less than 10% are on inhaled antibiotics. They're not used because our guidelines reserve them for people who are really, really sick. And then the thing about inhaled steroid, we just say don't use them in the guidelines. But we know that 20 to 30% of patients with bronchiectasis have features that are labeled as possible asthma, and that 20% have high blood eosinophils. So you can criticize and say 50% of patients with bronchiectasis in Europe are on inhaled steroid, so the doctors are wrong. I suspect the doctors in many cases are right. The doctors are seeing that when they prescribe this to some of their patients, they're treating a treatable trait. The patients feel better, the patients exacerbate less, and so that's why their use persists. So we need a more sophisticated approach to this. We need to think more about how we integrate the complexity of this disease. Because bronchiectasis patients are not simple. I'm going to tell you a very brief, funny story, which is me and Sanjay Chotamal wrote a review for the Lancet Respiratory Medicine, and we got a reviewer comment back that said, you haven't captured sufficiently the heterogeneity and the complexity of bronchiectasis. You need to have a figure where you describe all of the different subtypes and all of the complexity of bronchiectasis. And so we drew this, thinking that nobody would ever publish this because it's way too complicated, and that the editor would then let us get away with not putting in the figure, and they published it anyway. This is so complicated. But I do like it now because it illustrates a point, which is if you have even just these parameters, 10 possible parameters in terms of radiology pattern, microbiology, type of inflammation, you have all of these different causes that have different presentations and different severities. You have so many different combinations of patients that no two bronchiectasis patients will be the same when you review them. Every patient will be different. The way you illustrate that is if you go and try and break into somebody's office by punching in things on a keypad, with a 10 by 10, let's say you have to enter 4 numbers in here. How many different possible combinations are there? Anyone know the answer? Any mathematicians in the audience? Yeah, 10,000 possible combinations. Yeah? Bronchiectasis patients are way more complicated, and COPD patients and asthma patients are way more complicated than a 10-number combination lock. So our patients are incredibly complicated, and so we need to be much more sophisticated in the way we evaluate the patients. And this is the only slide that I'm going to show you that points towards what Alvar is going to tell you. Alvar is going to tell you the answer, which is the need to identify subtypes based on validated biomarkers that we would call endotypes, and those that are amenable to being treated, which is treatable traits. So I'm not going to delve too much more into that. But the other thing is, let's say our patient does have a treatable trait. Let's say they have eosinophilia or they have Pseudomonas infection. Does every patient that has those things need a therapy? Or are some patients relatively stable? We don't know. But one of the most important things then is, what is our patient's risk? Yeah, we're about managing risk. So go back to my guideline. I said 3 or more exacerbations you should treat. That's what the guideline says. Let me show you 2 patients. Patient number 1 has primary ciliary dyskinesia. They had 1 exacerbation in the last year. They're coughing up lots of sputum. They've got very severe symptoms. They have Pseudomonas, and they have chronic rhinosinusitis. The second patient has idiopathic bronchiectasis, 3 exacerbations in the last year. Their symptoms are bad, but not too bad. They have Haemophilus in their sputum, and they have cardiovascular disease. Which patient is at highest risk? Do we know? Yeah? The patient on the left is probably at higher risk. Okay? PCD, big risk factor for progression. That's genetic lack of cilia function. 1 exacerbation is obviously less than 3, but severe daily symptoms is a risk factor for exacerbation and progression. Pseudomonas is a major risk factor for exacerbation and progression. Chronic rhinosinusitis is a risk factor. None of these other things, apart from the 3 exacerbations, is a risk factor. So I'll show you now some unpublished data, or data that's about to be published in a couple of weeks in the Lancet Respiratory Medicine. This is Oriol's work. If you just take 2 of those variables, which is symptoms and exacerbations, and you look at the 1-year outcome for these patients based on their prior exacerbation history, if you've got average symptoms like that second patient, and you've had 3 exacerbations in the last year, you'll have, on average, 1.5 exacerbations the next year. That's what the data tells you. Yeah? Or if you've got slightly less severe symptoms, 1.36. If you're in that category of the patient who's got 1 prior exacerbation, but you've got really bad symptoms, you've got more exacerbations. You've got a higher risk of exacerbation. Now factor into this calculation the Pseudomonas, the rhinosinusitis, and the PCD. That number goes up, and that number on the right-hand side stays the same. So what I'm advocating is that when you see a patient with bronchiectasis, there is more to that assessment than just saying how many exacerbations have you had in the last year. The question should be, what risk factors has this patient got that means they're going to get worse in the future, that they're going to have more exacerbations? And that should include symptoms, their microbiology, their comorbidities. So we should make things simple, but we shouldn't make them so simple that we miss out on really important clinical information. And that's a bit like what we do in many other fields of medicine, including cardiovascular medicine. If I made a guideline that said you should only use statins if the patient smokes, one risk factor, that would be malpractice, because you need to take blood pressure, you need to take cholesterol, you need to take exercise, their family history of cardiovascular disease. Cardiovascular doctors don't get criticized for saying they're not simple enough. They just have well-defined risk factors that everybody looks at. So think about it in your patients. What risk factors do I ask about regularly? And do I recognize that those things put my patients at higher risk of exacerbation? Because we've got great data on this. There's multiple studies, mostly from big registries, that show all of these factors are risk factors for future events. So we should be able to create like a cardiovascular risk calculator or a cardiovascular risk card for bronchiectasis. Shouldn't be that hard. But in the meantime, we should at least be asking our patients about these things. And how does this link to new therapies? The most important question we're going to be asked is who should get these new therapies? And it's clearly going to be the patients that are at highest risk of exacerbation, which doesn't just come down to one number. And I think we should be thinking about how we modify the course of disease. Because a lot of our patients, we wait until they've got multiple exacerbations, their FEV1 is below 50, their lung scan looks bad, the house looks like this. Whereas you're going to have much better effect by calling the fire brigade when the house is at this stage. We should be thinking about how we prevent our patients from getting more and more damage rather than waiting until they have more damage and then introducing our antibiotic therapies. Another way of conceptualizing that is to think about patients in terms of disease activity. The fire is disease activity. The symptoms are disease activity. The exacerbations are disease activity. That's what is on the y-axis here. And some patients have really bad activity, meaning they're exacerbating a lot. They feel really bad, but their scan is not that impressive. Their FEV1 is well preserved. Those aren't your low priority patients. They're your high priority patients, because you can prevent them from getting to the stage where they are very severe and they have very extensive lung damage. And so as we get all of these exciting new therapies, it'd be great for us to also be thinking about how can we use them in a more sophisticated way to get the best outcomes for our patients. So in summary, current management of bronchiectasis today in 2025 is focused on antibiotics and airway clearance, but that is going to change because we've shown very clearly that targeting inflammation can make a big difference to patients. It reduces exacerbations, slows lung function decline, improves symptoms. There's a number of other novel anti-inflammatories in development, so this is a really exciting time also if you're involved in clinical trials for bronchiectasis, because there's lots of options we can give our patients. This is a new era for bronchiectasis, and so in addition to taking these new therapies, hopefully what I've also persuaded you is we need some new thinking about how we manage these patients and to learn from what diseases like asthma and COPD have taught us about the importance of targeting patients earlier and thinking about disease modification. So a massive thank you to my friends who've invited me here to visit you. Do you remember that picture, Gilly?
10 years ago.
Yeah. Doing a microbiology in the lab in Dundee. I really appreciate all of the fantastic collaboration that we've had with many colleagues in the room, my friends here in Barcelona. Really, really grateful for everything that you've all done to support bronchiectasis and to support me, and very happy to take some questions. You can tell bronchiectasis is exciting at the moment. I got so excited I broke the microphone.
Thank you, James, for a wonderful talk. Si alguien quiere hacer preguntas y prefiere hacerla en castellano, yo puedo traducir o hacerla directamente en inglés, como preferáis.
That was fantastic. Thank you very much. As you know, my field is COPD, not bronchiectasis, but at the end of the day, they are not that different. So do you know if any of these new therapies is running or considering trials in COPD?
Yeah, so I think
Not to speak that many COPD patients have bronchiectasis.
Yeah. So there's two parts to the answer. One is obviously the new BI study is including patients who have COPD as their main diagnosis, but they also have to have bronchiectasis. To my knowledge, nobody has initiated a trial of COPD specifically, although I've heard there may be one kicking off in China with the Chinese compound. But I think we need it. If you look at the Aspen trial data, they have a subgroup analysis by history of COPD or no COPD. At the 25 milligram dose, the benefit in no COPD is 20%. The benefit in bronchiectasis plus COPD is 30%. So is there any reason to believe that COPD alone would not respond? I think if you choose chronic bronchitic patients with EOs less than 300, that's all going to be neutrophil-driven COPD. I would do the trial tomorrow if somebody would support it.
Fully agree.
¿Alguien más?
Thank you very much for this nice talk. So, according to the current evidence, what do you think is the most promising drug for one, reducing exacerbations, and second, controlling symptoms? And finally, what about the non-colonized patients? Because I think all the drugs you presented were for the Pseudomonas aeruginosa. I don't know if I'm sure.
No, great question. So I'll take the last bit last. So the Aspen study enrolled patients with a history of exacerbation regardless of pathogens. So it was stratified by Pseudomonas, which is where the Pseudomonas from the slide came from. But patients in that study didn't have to have a pathogen, and most of them didn't. It was 1/3 had Pseudomonas. So brensocatib will work, we think, for almost everybody. If you look at the subgroup analyses, it works in every subpopulation that was tested. So history of exacerbations, there's a good chance brensocatib will be beneficial. So to your question on which one's most promising, the only one that's currently going through the regulatory process is brensocatib. So in terms of what are we going to be prescribing in the future, fingers crossed regulatory pathways go well, that's the one that we're going to be able to use. The other ones need to prove themselves because they're all going into phase 2 studies. But I think there's still room for improvement. If you look at the data, Brenzo reduces exacerbations, but not to zero. Brenzo reduces lung function decline, but there is still decline. And the symptom improvement is there, but there's room to improve. So I think brensocatib is fantastic, it's a great start. I also want to see those other drugs come through because patients will need multiple options.
More questions from the floor?
I have one question. It's more of an opinion-related question than a question itself. But considering brensocatib inclusion criteria, the patient had to have at least 2 exacerbations, and this is the drug that is more likely to be approved soon. So does it make sense to wait until the 2 exacerbations, considering your analogy of the burnt house and the house on fire? Should we probably look in the future to start this treatment before the patient has had 2 exacerbations?
Yeah, so at the moment, I imagine that the regulatory approval will be related to history of exacerbation because that's what the trial was, and that's usually what guidelines say. You should follow the trial evidence. I would like to see a study in early disease. So I think to answer your question, you need a study because the early disease patients were not included in that trial. But I would love to see a trial with DPP1 in early disease focused on disease modification. Can we prevent lung function decline? Can we prevent the CT from getting worse in patients who've got early disease? It's where COPD is going. It's where bronchiectasis needs to go, in my opinion. Because I don't think it makes sense to wait until the house is burnt down at all. And that's not what I do in my practice. So the guidelines say 3 or more exacerbations for macrolide, for example. If I've got a patient with 1 exacerbation who's coughing up buckets of sputum and their lung function declined 100 mils last year, I'm going to give them a macrolide. I'm not going to say, come back to me and see me when you've had 3 or when you've been hospitalized. That's not good medicine.
Of course.
Following up on this, you emphasize the importance of prevention and the house who has already been burned or not. How can we identify early disease in bronchiectasis? Because as you said, I mean, the diagnosis of bronchiectasis requires structural abnormalities. Is there any way you can thought of finding predictive factors of bronchiectasis, or really identify early disease?
So this is a focus of intense research, and it looks like there is a pre-bronchiectasis condition called persistent bacterial bronchitis. It's probably misnamed because bacteria are not always there, but this is now well recognized in pediatrics, multiple publications about this. So anyone who does these clinics will recognize these patients. You have a patient referred to you as query bronchiectasis. They've had symptoms for a year or 2 years. They're coughing up sputum. You do a CT, and the CT is normal, or the CT's got some mucus plugging and some bronchial wall thickness, but no bronchiectasis. And you do tests for asthma, they don't have asthma. You do spirometry, their lung function is normal, they don't smoke. What do those patients have? We've followed them up, so we've followed up a cohort of these patients. At 5 years, 25% of them have radiological bronchiectasis. So there is, I think, just like there is with COPD is preceded by smoking-related chronic bronchitis in many cases. In bronchiectasis, there is a preceding inflammatory-driven bronchitis that can be identified. And there's some studies in pediatrics that show if you treat aggressively with macrolide, for example, in those patients, you can see normalization or prevent bronchiectasis.
In COPD, now we recognize the importance of early life events and prematurity or repeated infections. Is there something similar in bronchiectasis?
Absolutely.
Do our prematurely born babies have more bronchiectasis?
Yes. Yeah. So the classic description in textbooks of bronchiectasis patients was childhood whooping cough or severe childhood pneumonia. So many of our patients have a history of that. But it is a complex disease. Many patients don't have a pediatric history, but they develop symptoms in their 30s or 40s. But there's no, like COPD, not every COPD case starts in childhood. A lot does. Same with bronchiectasis. I think there's so many similarities between bronchiectasis and COPD.
Are they different diseases or the same disease?
Yeah, I think
different manifestations.
Yeah. So the way I think about it is, you have an insult to the lung. Depending on your genetics and your epigenetics and your environmental exposure, the damage response may be you get airflow limitation. The damage response may be you get bronchial dilatation and bronchial remodeling. And in a lot of patients, you get both. So I see both of these as the same process, which is the lung trying to deal with damage. And people go down different pathways depending on the nature of their response.
How does emphysema fit in this view?
Yeah, so emphysema, everybody gets very confused about emphysema. One of my favorite papers that I published like 10 years ago was a study where we did CT scoring on people with bronchiectasis who had never smoked. And about 25% of them had emphysema. And the ones who had really high levels of neutrophil elastase had the worst emphysema. So why does emphysema happen? Emphysema doesn't happen because the lung is damaged by an infection. The emphysema happens because the body creates neutrophil proteases that destroy the lung structure. That can be caused by cigarette smoke, but it can also be caused by lots of other things. So even emphysema, the pathway is the same. How you get there is different, but the pathway is the same. It's protease-mediated damage, and there's loads of protease-mediated damage in bronchiectasis, which strengthens my view that anything that works in bronchiectasis should work in COPD. And particularly in early COPD. I mean, I think I'd be interested in your comment. In early COPD, the trials so far seem to be focused on bronchodilators, and that seems to be the wrong target. So you have early COPD, later you develop airflow obstruction, and airflow obstruction is treated with bronchodilators. But the initial insult in early COPD must be inflammatory. So why is it bronchodilators that are being trialed rather than anti-inflammatories in early COPD?
James, thank you very much. I have a short question, and it's about biomarkers. Do you think that we should need a biomarker to start these new treatments? And I'm thinking of neutrophil elastase in the sputum.
Yeah, great question. So this talk could really be titled "James is always wrong," because I keep telling you about things I got wrong. And the other thing that I got really wrong was I really thought that brensocatib would be like mepolizumab, where as the eosinophil count goes up, the response gets better. When we looked in the Willow trial, there's absolutely no relationship between the benefit and the drug and the biomarker. So it's completely different to what we see with the asthma drugs, where the biomarker predicts response. And the reason for that is we've kind of figured out is that your baseline level of elastase probably doesn't matter for your response to the drug, because what's happening is when you get an exacerbation, a virus comes in, neutrophil elastase is going through the roof. And what the drug is really doing is it's stopping you from raising the neutrophil elastase during exacerbation. So where you start, whether you start high or low, still goes up during exacerbation. So the drug works regardless of the biomarker. Does that make sense?
Yes.
Yeah? It's really annoying, because I thought it was going to work, and I thought we'd have a lovely biomarker that would tell you who to use the drug in, but it doesn't work.
Muy bien, pues si no hay más preguntas, thank you, James, for a lovely talk.